Good afternoon or good morning. My name is Dhaval Chauhan. I'm a fourth year student at Barry Podiatry. I'm presenting to you today, Getting Out of a Mess, Intraoperative Complications. You're going to have to work with me just a little bit, Dr. Hill. I'm sort of splitting my screen between the video and the PowerPoint, so a little bit of back and forth. Second slide, intraoperative complications, what are they exactly? So let's start out by defining sort of what they are not. So let's not mistake intraoperative complications for failures of treatment or improper corrections. Both of those things sort of fall into postoperative complications where you've either done the wrong thing or you were not able to necessarily get the proper correction. Now, intraoperative might play into that a little bit, but we're more specifically talking about what occurs during the particular surgery, what happens in the middle of the surgery. And so we'll get into a little bit more detail with the specific cases that I have as an example later in the PowerPoint. So if we could go to slide 3. Now, on this slide, you'll be able to see I have two graphs sort of presented. The smaller one on the right I want to begin with, that is the Clavien-Dindo system of operative, what they entitled operative complications. But whenever you sort of look into it, it's more talking about post-operative complications. So you don't really have to read it because, I know it's a lot of wording there, but basically, it's saying post-operative complication grade 1 is sort of those things that you would expect for, let's say, for example, edema, inflammation, swelling, that sort of thing that you don't necessarily have to intervene and treat. Now, grade 2, those are post-operative complications that you would want to start treatment. And grade 2 specifically is talking about treating with pharmaceuticals or drugs. And so I think some things that come to mind are like infections, that sort of thing. Grade 3, that's when we get back into surgical revision. So these are postoperative complications that require you to take that patient back into surgery. And those are broken down a little bit further. But if we go to grade 4, that's life-threatening postoperative complications. Now, the ones that we know of most commonly would be like DVT, PE, those sorts of things. Grade 5, is death, which is ultimately the worst thing that could possibly happen. I've seen the Clavien-Dindo system split up in different ways. They said grade 5 is, I've seen other ones that take it all the way up to grade 6. And then what I want you to really look at in this slide is that system on the left right there. Now, this is a proposed intraoperative complication classification scheme, and it was described by Kazarian et al. In 2016. So if we look, it's only grades 1 through 3, but they sort of kind of cover all the bases there. And because this is a very basic proposed system, it's not in current modern use. I think 3 grades is all right. So let's start by talking about grade 1. So this is incidents managed without changing the operative approach. So in their specific paper, they talk about like nicking a adjacent organ, which might result in an expected amount of blood loss. For us, I could see that as being, okay, well, maybe a little too much bony resection, or nicking a adjacent structure for us, a muscle perhaps. Something that won't necessarily change the course of the surgery, but something that you do obviously need to consider. Now, grade 2 is an incident with further consequences for the patient. And this includes sort of, in their specific example, that's nicking the adjacent structure, which leads to some sort of actual, loss of a significant amount of blood. For us, I could say, let's talk about like nicking an artery, nerve, vein, for example. And then grade 3 is incident leading to significant consequences for the patient. For us, all I can think of in those examples would be, nicking like a major vessel, dorsalis pedis, anterior tibial, posterior tibial artery, those sorts of things that can lead to ischemia, nicking a nerve, causing, a deficit, like a major deficit, deep peroneal, common peroneal, one of those causing foot drop later on. That would be like a grade 3 for us, I would think. So now, So let's talk about lapidus considerations. This is one of the procedures that was presented to us in our ACFAS videos, and it was presented by Dr. Reeves. So some of the main things he talked about during a lapidus procedure to fix these bunion deformities is adequate joint preparation for fusion. You obviously don't want to take away too much bone, but not taking away enough is going to really affect the way those adjacent bony structures are able to align and are able to join later on. The lateral release, I put a question mark there because he mentioned, do we want to do it every time? And so he says the way to figure that out is intraoperatively, once you open up the capsule, you try to push that bunion deformity back in laterally, and what that'll do is sort of tell you whether or not that deformity is rigid or flexible. If it's flexible, he says you don't necessarily have to do that lateral release. If it's rigid, you will have to. But he said in general, it's not a bad idea to do it anyways. And then, of course, reduction and fixation. So here I present you with a picture that's showing you two wires. Now, the two wires, the first wire he places in, this is Dr. Reeves' surgical case right here. So the first wire he places in order to get that IM angle reduction. And then that second wire he places in to control that rotational deformity. And he says, he didn't really see that too often, but it is something that he does with his residents, and I think that it does present, I think it is a good idea to do. So if we talk about further considerations, what are we trying to do here? We're trying to correct that first MBJ and sesamoidal sort of alignment. We're trying to realign them in the proper position. So all of that involves preoperative planning, taking those x-rays, but it can also involve the intraoperative x-ray where, after you finish, is that in the correct position? Is that where I want it to be? And if it is, then I think you're good. So on slide 5, I have that as a procedural consideration, and then the other considerations are, of course, the first MBJ contracture, that intercuneiform instability. That's to say, if you open up the patient and realize, oh man, these bones are soft, they're not in proper alignment, maybe this fusion isn't going to go the way I thought it would, that would be sort of intraoperative complication that you would have, that the surgeon would find themselves, trying to work around. This first metatarsal base flare, that doesn't present a problem initially, but post-operatively, that can result in pain on the second metatarsal. So intraoperatively, you might want to, if you detect that base flare, then you might want to resect that out. So slide 6, a couple of pearls that we see is, sorry, I lost my place. There we go. Intraoperative x-rays are a must, of course. Stress test. Check to see if that alignment is correct. Check, pull it, see how wide that IM angle can go. And then third, pull out the hardware if need be. If you put your hardware in and realize, oh no, this is in the wrong position when you're doing your stress test, take it out, put it back in. You're good. So, slide 7, let's talk about triple arthrodesis for a minute. So this is last resort, but the gold standard for hindfoot pain. Now, hindfoot pain is a very broad term, but more specifically, we're talking about like PTTD, painful pes planus, that, hard, painful flat foot. We're talking about post-traumatic arthritis. So the joints involved are the subtalar joint, the talonavicular, and the calcaneocuboid. And that will help me work into this next slide where we're talking about surgical considerations. Now, do we want to do one incision or two? We could do the one giant lateral incision, but that won't provide a lot of visualization for us. So we might have to do a lateral incision and a medial incision. So the lateral will take care of subtalar and calcaneocuboid joint. Medial will be able to visualize that talonavicular joint. Now, why is this important? Intraoperatively, you want to have that proper joint resection. That way the adjacent bones are able to align and are able to fuse properly. Again, this is one of the main things for us considering we do a lot of orthopedic work. You want to make sure you have adequate joint resection. Again, fixation and hardware, these are, real big issues here where you want to take those intraoperative x-rays. You want to make sure those things are properly aligned. I have two pictures right there. They aren't from the same patient, but they're showing sort of the same intraoperative complication where the surgeon has placed the screw, the subtalar fusion screw, in a way that isn't midline. Now, if you don't do that, post-operatively, whenever that patient is weight-bearing, you might be able to, or they may experience stress fractures or pain right in that area. You can see in the second picture on the bottom right that the surgeon had placed the screw not midline and stress fracture occurred on the other side of it. So again, take those intraoperative x-rays. If it's in malposition, take it out, and then realign and place it back in. Slide 9. Considerations for the triple arthrodesis. Dr. Merrill touted this all through our class. You shall not varus. Do not varus the foot. Now here you can see a X-ray post-operatively weight bearing where that the base of the fifth metatarsal is contacting the ground. It's purchasing the ground. And, in a normal patient, that will cause, painful callus. And I say normal, I mean immunocompetent patient, no comorbidities, that sort of thing. That'll cause still a painful callus, and it's going to really mess with the biomechanics of the way a person walks. But if you're talking about somebody that is immunocompromised, and most often we think of, that diabetic patient, right here you can see this ulcer formed. And, once the ulcer forms, and especially in an immunocompromised patient, that's going to lead to just an array of post-operative complications. So the intraoperative sort of considerations that we have to think about on slide 10 is these three sort of deforming forces. So I have three images from left to right. So beginning with the first one, we want to correct that residual abduction deformity, and we can do that by doing a medial-based closing wedge osteotomy through the talonavicular and calcaneocuboid fusion sites. The second one, you want to correct that varus. Again, that fifth metatarsal, you don't want it purchasing the ground. Again, with this, you do a closing wedge osteotomy through the subtalar joint. And you can maybe add on a calcaneal osteotomy or a midfoot osteotomy. Either way, you correct that varus, and even if you put them in a little bit more valgus, that's okay. This last image is correcting that residual supinatus with a derotational osteotomy through the talonavicular and calcaneocuboid. Those will all result in a much better sort of fusion, much better positioning. And these are all things that you sort of have to, load the patient's foot on during the operation. So intraoperatively load that foot and see sort of what position they're in. So in conclusion, intraoperative complications are unavoidable for anyone, even the most brilliant, perfect surgeon. You have to correct as you go. That means taking your intraoperative x-rays. That means loading the foot during the operation, seeing sort of what position it's in. And then, of course, even if you do all of this, who knows, something can happen, something will happen. So revise later if needed. So this little comic says, time wounds, all heals. And that's all you can really hope for. Just, doing the surgery and then giving it time, seeing if it heals properly. And if it doesn't, well, then you got to take them back in, fix whatever the pathology is, and hope for the best. Thank you.